is great for those who are seeking. But are we creating just barrier to care by also focusing on those who are seeking versus outreaching to those who might not be able to seek care for themselves or might not have the barrier that will prevent them from seeking care.
Right. Yeah, no, I agree. It should, actually, maybe it's just Vermonters should have whole health support, or Vermonters
In need of.
or something where it's not about them actively seeking care.
Right.
You've got systemic, issues, you've got
Barriers.
healthcare disparities, you've got access issues. You have a whole range of obstacles and barriers that are getting in the way, including transportation, I mean, all of the social contributors of health and, or even political, as we heard the term political determinants of health that might impact people seeking. So some way of, and I don't know about the wordsmithing of it.
Yeah.
I would agree that that should be expanded or should be reworded somehow.
Yeah, I would add to that on the clinical side. That we know, especially with mental health diagnoses, engaging in care is a symptom other than the disability. And so I think that we're framing it as someone has to engage in care or already eliminating. We're expecting people not to have a symptom of the condition that we're trying to intervene.
Great point.
Yeah, if we're gonna be reaching out to people with, that have been historically marginalized, they're not the ones, they're not gonna walk to, oh, yes, here. Of course, we wanna be where people are at. I mean, now we're looking at connecting and doing care coordination in libraries and in other places where it's like, that's where people are at, and that's us and our responsibility. I'm speaking as a designated agency, sort of doing that kind of outreach, of course, within the funding that we have available.
Right.
And that becomes a challenge, but I think that does address some of these issues, but.
It's really
in terms of wording,
traditional medical places.
Yeah.
Places.
Yeah.
Facilities.
Model.
What about flipping, like care for Vermonters should include whole health support or something, like gets away that
Yeah.
active.
Right.
The other thing that I have with that first sentence is whole health support assumes a known definition of whole health.
I was just gonna say the same thing, that where's the definition?
Question.
Care practices. How do you integrate peers and how do you provide trainings that are not based on that? Well, I can speak.
I don't hear a lot of support. I know superficial. And I think that's
This space, have been saying peers alone.
Yeah, there's the whole health model, but I think we're talking more broadly about general whole health, that your healthcare is
Right.
inclusive of your physical, your mental, your oral.
I think of the key drivers for health outcomes. Things population demographic, where it shows like the percent breakdown of socioeconomic factors, employment, housing, those things are key drivers. I mean, I feel like that encompasses, we're talking about these things that drive health outcomes, and we know 40% of them are non-clinical related, they're all behavioral,
Yeah.
things that are happening in your daily life.
Yeah.
And, does that help define whole health?
Well, I think it's getting it, like addressing some of those barriers that we've talked about, like for those, the same issues we had around the word seeking. It's like whole health is all of the parts of your body are all connected and they all impact
Yeah.
each other. And then also your environmental and social and political factors that impact.
I mean, I just go back to my social work days, person and environment.
Yeah.
Like
Also connected.
Turns out.
So it's, but with this, we're also saying that this embedded staff person would need to be able to identify and because if the person hasn't self-identified by seeking care, then there's a step that, if someone's self-identified, you can address it, right? But if they're not.
Well, yeah, and I think that gets into the screening, brief intervention, navigation to services.
So I'm assuming because we are in the integration of primary care workers,
Mhm.
right? So, at least for the time being, so this embedded staff person is someone who is within the primary care,
Correct.
pediatric care. I don't know about urgent care now, ER, that's a whole nother piece to it, but I just want to clarify that that's really I don't want to say limited, but in a sort of in terms of defining, that's what we're talking about. Because I do think, way more broadly, I do think it's important to have staff embedded within other, like I just mentioned, the library is a huge issue in our community, this is Brattleboro. The library or law enforcement or schools or drop-in center, there's all the other places where people, where staff could be embedded that could
Right.
bring a whole range of services, particularly if, there's some major significant issues and then connecting them to primary care and physical health care, if you will.
Yeah,
But in any event, yeah, I just wanted to.
it's an interesting point. And Sam, I don't think we ever really addressed that in the work group. I think we looked at it from the perspective of, so we have primary care, we have people coming into the primary care office, which is often a great opportunity to identify, screen, and then connect them with additional services. But, also then how do you, if we're looking at an integrated system, how do you capture them outside of, and then that can also connect them with primary care, and also connect them with
Right.
additional services, and
Right.
like, primary care, but it's gotta be that network of.
Yeah, one of the things we're doing locally, not to go too far afield, but we are moving towards becoming a CCBHC certified community
Yep.
health center, and our primary model is care coordination.
Mhm.
So we've hired transition, discharge, and LPN, and I think 5 care coordinators, and they're going to be embedded and working very closely with our AAA, area agency on aging, with pediatric folk. I mean, they're coming to a school. We're going to be talking about how do we work with schools to identify folks that aren't connected and then bringing them to primary. And then the idea is to connect them to primary care
Right.
because oftentimes we don't have primary care.
Yeah,
Unless they have a real wraparound package, as folks with developmental disabilities, for instance, might have a waiver where it's pretty, well put together, there's a lot of their staffing to support that, but in many cases they're not, or they have chosen not to, or whatever.
Right.
So that's, so they're really going to where people are at to sort of create those connections to primary care.
Right.
Because the assumption is that, the idea is that many people don't either have access or whatever.
So I think like embedded staff, is it really that they need to be embedded in a physical primary care building, or really are they embedded in the community in places where people frequent, and they can also be present in the primary care office? Like,
so
is there,
having someone embedded in the primary care, we've been talking to a lot of the primary care providers, is really having that access to an embedded staff where you're talking with someone. You've asked them a question, it's like, you know what, I really want you to talk to this person, and you can send them down the hallway, and then that person can kind of carry that
Right.
big baton and run and help connect that person to the right care.
Mhm.
And I think the other thing about having someone embedded and like having it physically in the building is it's a reduction of the stigma. It's like, oh, okay, you have this other facet of your body mind that we're gonna link you up with someone, they're gonna
Mhm.
help you on the next phase.
Well, can you,
Um,
this is
So I like, just because that's my background, working with the primary care providers, that's an important part, but I like the idea of this bi-directional. How are we also reaching out to communities? I know that's an area that FQHCs also do a lot of work with, building with their communities, and then partnering, especially around the CCBHCs, where they're one of those required partners. But yeah, I'm wondering, what I'm hearing is maybe adding a little bi-directional, but whether it's one of the recommendations.
I
like
actually
community
call
bi-
it multi-directional.
Yeah, multi-directional.
Bi-directional is you got a clinician that
Yeah.
you've got a mental health, or peer
Yeah,
who's there, and then it's got, that's going back and forth, but a multi-directional is really improving access, reducing the disparities that get in the way of people
Mhm.
connecting with primary care, or I don't know, even like a dentist, that's a whole other conversation. But really connecting them, because and that is part of the protocol, it's part of the, the workflow, if you will, or the culture. Where
Okay. I'm just handing them to Kathy and saying, here, Kathy, I did my job.
People would just rotate, like I could ask that, come here, and if this group
I'm
would
certainly
go
not
to
helping.
pediatrics, and I'm gonna have pediatric.
Are these comments for us on the thing that I'm seeing?
This is, when I hit record, it did transcribe as well, so Kathy can go back
I was
and.
like, that's a lot of chats.
Yeah, it's like, chats are blowing up.
I know. I don't know if it's even gonna make sense to her, like, is it picking up every
Oh.
word? I don't know, but
I think one follow-up
Yeah.
to this before we
Yeah.
switch is that with that context of primary care, I think, so our program works with almost 100 primary care services in the states. There is a huge difference across practices in terms of access to this type of person.
Mhm.
And I think that maybe having kind of short-term and long-term recommendations may be a good way to address this, is that initially we really just need to make sure that, anyone who comes into a primary care practice has similar access to this type of support, and not if I go to, FOH, if I go to community health centers, Burlington, I have this, but if I go somewhere else, I don't. But then recognizing that mental health, because people with mental health disorders may be seeking care, that there's a second piece of this that beyond the people coming into the primary care clinic, that links with the other work group that's done in terms of intervention.
yeah, that's a great thought. And we've often had that thought around DAs, like, they're just different enough that sometimes if you go to NKHS, it's very different than going to HCRS. And so do we have like base similarities? Yeah, and I think that will be CCBHCs will
That's-
find
yeah.
some of those.
yeah.
And we're
definitely-
realizing that with alternative TEDs is everybody's a little different.
That's a really good point, like, is one of the recommendations, like, what are the core?
Yeah.
The core, sort of,
It's a really good.
services or components of this integration that we're hoping every primary care setting. And I think we have to be pretty, because it's a range, right? Like, it's like if you talk about Northern Green Mountain Family Practice in Swanton,
Right,
it's 3 nurse practitioners,
right.
right? And those are the 3 providers for that whole region versus, someplace like Community Health Centers, Riverside, that has a huge,
Yeah.
yeah. So I think it has to be very, one of those very
Yeah.
essential pieces that we, that can be. And I think this also gets to the shared resources, like, does someplace like North Carolina Family Practice with 3 nurse practitioners share someone with, enough practice? And how are we looking at practice that are doing this really well? So are we using that experience to help other clinics that haven't done that yet?
Yes.
Be able to do it, and are we tapping into that expertise that's gonna be there?
I know we're just supposed to transition, but I would add that Blueprint's expansion with mental health is kind of getting at that exact thing. Like if you have X number of Medicaid patients, you get 1 FTE embedded. If you have more, you get 2 FTEs. If you have less, then you are part of like the shared resource of like a community health team worker.
That's the,
Yeah.
but it is still based off of Medicaid.
Yeah.
Who are receiving Medicaid.
Because now we're getting into the disparities of like
Right.
different.
Yeah.
Plans.
There's a lot
Wouldn't it be
of-
great if we had an alternate?
What? Okay, you guys. Well,
So if you want to join pediatric, Nicole and Julie, thank you. Yeah. Hi, nice to meet you. When you introduce yourself, I'm like, oh. I just sent her an email.
Yeah. I know, it. I'm like, having I was out for several weeks. And I was.
Yeah. So
Yeah.
we're in.
And so I was like, did you see
You're on
that?
email too?
Did you see that? I like sent you a little email. I was like, oh, sorry.
That's totally fine, because, our minister. Oh, so sorry. Sorry, we got excited. Our administrative assistant came. I don't think so. So let me go for you. Oh, yeah, yes. Yeah. Okay. Yeah. Okay, sounds good. Thank you.
Group of one, except maybe there's some online people they're supposed to be following. I don't know.
They would pop on if
There
we
were
had
only two of us. Walt from VPS was.
Oh, so
sort of
Walt
travel-
should be popping on,
Okay.
hopefully.
There's a lot of.
So what I'm really happy about is there's lots of materials.
There is, and so there's this, and then we received this feedback from not retained, give us feedback, and then this was from.
Yeah,
Will.
I've got both of those.
Okay, and then this is your. And so in this last group, I can kind of review,
That
we
would be great.
picked this first one that we went through, and so from others seeking care, that one. And so really, they brought great points around, so by just saying seeking care, you're eliminating or discriminating against a subset of people that are not seeking care. And so, they wanted to expand that language. And then also whole health support. And they're like, what is that? Like, can you define that somewhere so that everybody has the same knowledge of what that means? As they talked about how the differences of one person sitting at the table was not the same definition of home health, whole health support. So,
Oh, well, because you.
and then, George from
HCR
HCR also talked about how
You might fall apart.
this is talking about people that just walk into a primary care practice. And so what about all those people?
So
We look
that's-
at non-traditional
field of
medical
for-
centers. So
Why?
people go into the library and they're at the
Equally
library for the
wide
day, and we look at how can we embed someone there
Right.
to provide
Right.
the medical supports to either connect them or at least build the rapport.
Yeah, connection and relationship.
Yep, so I thought that was a great idea. And then what else?
And
They had not-
Define
well, it's a big
embodied.
group. I'm not gonna feel like I have to come up with
Oh,
many.
God, no. But, with CCBHCs, they talked about how that may help with a lot of the care coordination that's gonna come with that. And so he's hopeful with that. But also having, such great ideas. I'm like, that by having an embedded care specialist in primary care, it
Right.
also breaks down the stigma with those medical providers.
Absolutely it does.
And so that was, how are we talking
We are
about that?
teachers and change agents in so
Yes.
many ways. We
Exactly.
change the face of mental illness.
Yeah.
Yeah, I love that people
Put that
caught that.
into the face.
Yeah, right? Cause like
Yeah.
the face that people know is, I'll just use myself as an example, me with no shoes on screaming on the street corner.
Yes,
Well, I'm
Yeah.
this me too.
right. And so which face do,
They're just, we don't have the
the media presence, like we know people recover from substance abuse, right? Because celebrities talk about it
Oh, yeah.
more.
It's true.
You get those coins, I'm
Yeah.
both, you get, you get a lot of recognition. With the MI stuff, I say mental illness,
Yeah.
but not so much,
Yeah.
right? It's still like, why are you telling people this?
Yeah.
Don't you know you shouldn't let anybody know this?
Yeah, there's still a huge.
So we
stigma.
do a lot of, I think, public relations work.
Yeah. Very good.
And we have this all the time where I might be working with a colleague. We might have developed a really good relationship with them.
Legally obligated to have.
But then say they go to the hospital,
Mhm.
you know, kind of ties are kind of severed.
Who has.
Yep.
Then we want them to see a primary care provider.
Sorry, I'm trying to like that.
It feels like, oh, is that primary care provider gonna be gentle and nice
Yeah.
and patient with them?
Yeah.
Because they all aren't, and for very good reasons.
Right.
They're overwhelmed and
Right.
have to do a gazillion visits a day themselves.
Yep.
And so like something to bridge all that.
Yeah.
I mean,
I thought it was interesting. I'm gonna blank on her name. I was sitting right there at that table at the end, brought up the comment about the mental health care of providers and how there's so many out on medical leave now because of
yes,
mental health. And so no one's talking about, that's the first time I've ever heard that.
that was really
And
important.
besides like just knowing it, like just in a conversation for her to bring that up, I had no idea the number of providers that were.
It
And
is huge.
so
It's significant.
I feel like it's so true in the medical world. I feel like coming out of COVID too, we're seeing it in the medical world, the mental health world, and then with teachers, we see like tons just leaving the field completely, which, you know, kind of breaks your heart a little bit to know that everybody is leaving. So
It absolutely
They're-
does.
they're just burnt. Like people are just tired. And so like all three of these professions, you're just seeing this mass exodus.
The mass exodus, and then I don't specialize in this, so I don't
Yeah.
wanna look at the numbers, but I don't know, what the numbers are of people, pursuing social work degrees, coming into the field.
Bias.
Young
yeah.
professionals choosing the helping professions, including teaching, and I think, people are just, there's, the population, it's just not as large as it used to be, right? We
Yeah.
just don't have, like, people having huge families for the most
Yeah.
part. So there's just less people anyway.
Yeah.
And then I think, this younger generation, I don't want to be an ageist, but they're sort of like, they're like, we're not gonna put up with this.
Yeah.
job."
It's so true. It's so true. They don't want to
And
be
I-
paid the $15 an hour.
And I love the spirit.
80 hours a week, and it's so true.
And I love the spirit of it, but is there a way to make it work?
Incorporates a term of implicit bias right in it. So it's like, here's where we still have so far to go. Because it's using.
Even with, it's so funny because even with my son, who's now, he just turned 20. And so he entered the workforce and he went off to the Air Force, came back, and then he's doing an apprenticeship for plumbing and that's like $18 an hour. So I'm like, Lane, are you gonna be able to make ends meet? He's got an apartment. I'm like, you may have to find like a job on Saturdays to make ends meet. And he's like, what? And that's like,
Such a good imitation.
you make work more than 40 hours a week, make ends meet. And like, it's mind blowing. And it's incredible hard worker, like not, but like to think that you have to get a second job.
Yeah.
It's just the mentality of the younger,
Yeah.
a lot of the younger generation that I'm seeing, and good for them in many ways, because I
Right,
feel
good
like
for them
now
in many
we're
ways.
in this place of feeling a little burnt.
Yes.
And
Yes. Yes.
wanting that work-life balance more. So
Yeah. And how to encourage people to continue to come into the field. Now, obviously at an agency like Howard Center, we expect that this is gonna happen. People get their graduate degree and they come into a DA to get their training, their supervision hours. They get that, and then they go into private practice.
Yes.
That's our name in Vermont.
You know, that happens all
They.
the time.
Oh, yeah.
I don't think there's, I don't think it's okay. I think it's part of the process. But is there a way to look at some of that too?
Yeah, and I know that there's like,
There are lots of examples.
that there's a way of providing supervision for licensure is a huge commitment. And it's,
Obviously.
it can be a burden on the agency to do that.
It's also-
So
it's a
is
lot.
there an opportunity to say, we'll provide you licensure supervision, but we need you to stay X amount of time to pay
Right.
back the agency your
Right.
work, you know, and I know they're doing that with nursing degrees
They
now.
are.
And my niece is in nursing at UVM, and she's getting quite a bit of scholarship, but she has to agree to work in the state of Vermont for every year that she takes the scholarship.
I think so. Fair.
Yeah, I think so
Right.
too. And so
That's
can
creative.
yeah. And
Yeah.
it's keeping people in Vermont and the younger generation in Vermont, getting nurses to stay in Vermont. It's helping them financially. It's keeping the cost down at the hospital so they don't have to have travelers, which is expensive.
Probably in the legislation thing.
Well, and you've got regular nurses.
Yeah.
Leaving, resigning to become travel
Yeah.
nurses because it pays so much
Oh,
better.
Yeah. So it's an interesting way to hit it, and I think it's smart. But is there a way to do that with supervision, you know, to work that? I don't know what it would be, like equal, but something like that.
Everyone knows.
And, you know, I know it's just not about money, but I always say people that have these like really amazing careers in like service work, they get more real estate in heaven, but like, you can't really cultivate.
Yeah.
You know what I mean?
Yeah.
So there gotta be a little more than that.
Yeah.
To continue to attract a diverse and vital workforce. I think with the peer specialist workforce in particular, in Vermont, people just aren't aware of it.
Mm-mm. I
Which is
also
so
think,
draining.
I know, and we're way behind the time, like
In that
in
particular
Vermont.
spot.
Mhm.
It's
And
so
usually
crazy.
we're way up
I
ahead,
had
right?
no idea frankly when I came up here from New York.
Yeah. Oh, you must have been like,
Heard that said.
so,
And
let me ask you this, because I recently heard this, that everybody's talking about peer specialists, like embedded in primary care, embedded for law enforcement, embedded at the designated agencies, embedded with mobile crisis, like embedded everywhere. And then I heard someone that identifies, so if they're identifying as having a mental illness, but they're not a peer specialist, right? They're not working as a peer specialist. So I don't want to call them that, but he's like, I think everybody is looking to have peer specialists to fill the staffing gaps that are in our world now.
Mhm.
And we ourselves have staffing gaps. And so we cannot look to have peer specialists fill those gaps. And so I heard him say that and I was like, oh, interesting. I hadn't thought of that either. Do you think that's true? Do you think others do you see?
I mean, I think it's becoming more known, but like at Howard Center, I really pushed for full-time positions.
Yeah.
For like, when I first arrived, the team that were all like sort of peer specialists, but they were identified, the job title was community recovery specialist, like peer wasn't even in the job title. And it was like, oh, a peer specialist is a viable discipline for me to look at.
Yeah,
And I
Yeah.
could do, have just you might call it entry level, you might call it whatever, but it's just not that well known yet, the
Yeah.
role. Whereas, in different states, like, it's very competitive. Peer
Wow.
specialist positions are very powerful and very competitive.
No, and I do wonder too, is there, we try to.
And I do, again, stand by the work of the Vermont Peer Workforce Development Initiative. They've
Yeah.
done tremendous work. I do happen to be on the steering committee, but
yeah,
they've just been making like tremendous progress with the certification process and this,
Yeah.
that, and the other thing. So, I mean, it's coming.
it is.
I feel like I've been here almost 6 years and there's definitely been momentum.
More progress
Mhm.
than,
And part of the thing that I'm stable, like,
Yeah.
starting to go out.
And it's the idea of people working as peer specialists is a win-win because all of a sudden you can be speaking to somebody that's in a mental health crisis.
yeah,
And it's not as though you like expect them to be able to jump from A to B.
Yeah.
But all of a sudden it's like, well, maybe that's something I could do.
yeah, yeah,
And you're like, yeah, absolutely.
yeah.
It's something
So
you
it's
could
like
do.
a goal.
You know what I
When you're
mean?
talking to someone.
Sure. We're modeling hope.
Mm-hmm.
And we've had a little bit of conversation today about resilience.
Yeah.
And my signature on my email is, it's not about resilience, it's resistance. It's resisting what people tell us we can't do, or you have this diagnosis now, so put away your plans for a great life. Because people are still getting this message. Put all those plans away.
Yeah.
And then we wonder, why do people with significant mental illness like sit in their apartments or their rooms watching TV and smoking? Because they've been told,
What are the
They
barriers?
can't.
in some cases, that's like what they can do.
That's the limitation.
You're not as good as us because you're doing mental health.
But that I feel like it does go with this whole, when you talk about the integration of peer specialists into all these various spots.
Yeah.
Was an invited part of this council and never participated.
So in many ways,
Because they were supposed to be here.
Peers. is it peer support certification? Is that what they're calling it?
Peer specialists.
Peer specialist certification?
So that you're not sending doctors out who are, well, we're better, our specialty is
Um,
better.
So by doing outreach is modeling.
But when we
When you're modeling the whole body wellness.
Yeah, for sure.
Okay. That's good.
And again, I think it's so important to hit, like we model it for our clinical colleagues.
Mm-hmm.
It's sort of like I can remember in New York City one time, I worked on a mobile crisis team that also did treatment, ongoing treatment. And the social workers would feel really bad if they had to, do an involuntary hospitalization. And
Yeah.
they'd feel like, come back and feel kind of like,
Yeah.
And I would just, like, every now and again, I'd go to my, like, listen, involuntary hospitalization is one of the things that's helped save my life.
Yeah.
So thank you for the work you do.
Yeah.
That's
We just have
really
those,
super powerful.
right?
Yeah.
Scared that,
Understanding, because you
you know,
often
you're
hear
not as good.
how
And as
horrible
long as
it is.
other than-
And
I don't recommend it.
Right. Right. I wouldn't recommend it either, but it is there for those times where it's saving someone's
You
life.
guys are the best. And therefore,
Right.
we're feeling like.
And it never feels good
Provide
to
Right.
take that away from
Because so much, like, especially I think
that.
medical, I think probably medical emergency staff know that people get better.
Yeah.
For whatever reason, they just know it.
Yeah.
This is why you.
But with mental health crisis, I think that people don't know that like people do get better.
Yeah.
Do well, and then they never know it.
Yeah.
So it's also getting that message
Yeah.
to our providers.
The non-state.
That, like,
entities make commitments.
Um,
I didn't hear any commitments from the hospital.
people, do
The integration.
get better. And we should expect, we call it now recovery, that's becoming questionable language, but We should expect that. Well,
Yeah.
we should expect wellness. I prefer the language wellness, really.
But that's not getting to this level of
That's
systemic
good.
and hospitals
So,
widening.
What are your thoughts around joining the
What do you
PACE
consider?
certification with
Why it's
substance
better,
use
and
certification?
why
Well, there's a lot of talk about that. I feel like they're two very different things.
Yeah,
Like, what do you mean by joining with?
Lock 'em up there.
So at one point, there was talk about having one certification for mental health.
Yeah.
Substance use.
The
The thought was, what I had heard is substance use specialists felt like that would be okay, and then mental health specialists felt like that was not okay.
bias
The
and.
couple of points I would make on that is that there is still a tremendous disparity in acceptance and appreciation for the mental
What is our
health
fear at that end?
recovery.
By joining,
For where these.
by joining.
Yeah, we just don't have the same level of regard and respect.
Yeah,
So I mean, I think that that's why we don't want to kind of, surrender our identity. And plus, from my opinion, because I am both, there are very different recovery paradigms.
yeah.
They're very different.
Yeah.
Like substance abuse, it's sort of like, 12-step, like.
Sorry, you're trying to.
Okay.
Yes, no, but like,
Oh, finish your thought though. I want to hear it.
there's actually a blog. I just ran across a really cool blog article that says peer support versus 12-step groups. What's the difference?
Yeah.
And there's some very significant differences.
I know.
So I think that's what's important to remember. And also, it's like, for me, I think addiction's easy. It's like, if I don't pick up, you're good.
Right.
I can't say the same with my mental health side.
Right.
I can be doing everything and still have
Symptoms.
an episode,
Yeah.
whatever you want to call
Yeah.
it. Do you know what I mean?
Yeah.
So I think there's important reasons for us to kind of be
Good reason.
respectful of that and aware of that.
Yeah, that's good. Thank you.
Thank you.
Education.
Thank you.
So you're gonna go to right, go out, go left, and you'll see it right in front of you.
It's already, 15 years, but that money we be certified without the 608 hours that have to be. They have to.
Hi. I think you might go there and they have to come here. They just haven't moved yet. They're working on moving.
Primary care.
Hi. Did anybody join? Oh, Walt joined there.
There were, Simone, Sandy.
DMH
Over
doesn't
there.
say.
Okay. Maybe they'll join here. We had no one join last
Oh,
time.
really?
And it was
They didn't
just-
follow us though. They weren't with us the first time.
Oh, so everybody's just doing whatever they want. Which works.
I have to head out early, so apologies.
Okay, no. Totally understand.
Gotta get back in the
This
car.
has been a long time. Oh, it's fun. Okay, so then.
Primary care.
Primary care. So we have this and this feedback. This is from, Will Everly. And then this is from Vermont Retain already gave, feedback. This is the summary of the interim, work group's recommendations. And so, so if we can look at the first one, which is from honor seeking care, that first one, that's under the
Okay.
recommendations, yep,
Okay. Yeah, that's.
yep, the first one there. And, let me see if anybody's online before I go. Okay, Hi, Sandy.
Good stuff here.
We are just starting primary care. And I was saying that we're gonna look at the interim work group recommendations. And if we could start with the first one, which is Vermonters seeking care should have whole health support, that one. And so far received a lot of great feedback from the first two groups that have been here, really talking about, I'll kick it off and then I want to hear from you guys, but they said Vermonters seeking care, by just saying seeking care, you're already eliminating a group of folks that don't seek care. And so oftentimes those are the individuals that have been diagnosed with the most severe mental illness. So just by doing that, by saying Vermonters seeking care, you're already eliminating a subset of individuals.
Mm.
And then some other feedback about that same sentence is whole health support. And do we have a definition of that? So we're all working from the same definition. In the first group, there was different thoughts about what that meant. So great point, we don't all come at that with the same knowledge and same information. So that was some of the work of the first and second group that we met with, and so just wanted to hear perspectives on that. Other thoughts about this first recommendation?
Yeah, no, that makes a lot of sense. And one of the things that says should be made available to all. It could say in through the ways or by the ways that make it most accessible for them. That may not be the best wording, but that concept
Yeah.
anyway.
So this, I was just gonna say, thinking about, since now about the way feedback about folks who might not be seeking care, but there's something, it's gonna be a little messy, but
Yeah.
there's something about the very end, right, about the you being available to all. Because in my mind, if the flip side of that is going out to, or
Yeah.
trying to bring to or meet people where they are, like if there's
Right.
something in there instead of just
Yeah.
making it available as.
And people don't
Yeah.
come. That
Yeah.
was one of the thoughts that George had shared, that they are looking at working with the library to be a place where people could connect, maybe with a primary care or medical provider, and at least start building that rapport to get them into an office. With the library looking at non-traditional medical facilities.
And boy, that's what it takes to use peer support
Yeah,
experts, rather, you're not gonna get the doctors.
Right.
The funding to get
Right.
doctors to go to the library, but peer support specialists would be a great role.
yeah,
And again, for, that, we're only talking about mental health substance use, but for all kinds of conditions where people don't feel they have access.
Yeah.
Other inequities.
In Rutland, we have the CCBHC yet to be
Yeah.
released for Vermont project going on, and we've hired an EPRN and are also hiring a nurse and some care coordinators who are facilitating people. And we're starting with our SED folks.
Yeah.
In getting them primary care screening and some, initial lab testing if they want it and things like that, so that we can try and make those connections and then monitor it long-term, like
Yeah.
make sure that they get referrals
Yeah.
to where they need to go to address the different issues and support them, and hopefully also like provide some education to folks who are working in the medical field.
So
Who might
having
not
like,
be like really attending to the fact that the person has enormous anxiety going to
Yeah.
this appointment, and you being, punitive about the fact that they haven't exercised as much as you want them to, might make them not want to come back the next
Right.
time. And,
right,
just, there's so much work there to be done.
yeah. So is the medical professionals right at Rutland Mental
Yes.
Health?
It's
Right.
embedded right in the,
Mm.
in the building where substance use services take place.
Yes, so, I guess part of what I was also asking, yes, and, part of what I was asking, how, is there the conversation, that is still about sites right? Like,
Right.
that assumption that people
Yeah.
are able to get to that site, B, have transportation.
Yeah.
Have,
Yep.
you know, inclinations, like, there's
Completely.
another kind of.
Yeah. For us, part of it is the peer specialist piece.
Yeah.
Trying to get them out to make sure that people know about the service, but it is a huge challenge, especially in rural communities.
Yeah.
I think, I'm always thinking of people that like live outside of Rutland City.
Yeah.
Yeah.
We're getting that.
And
So much Vermont is.
Yeah,
rural.
absolutely.
Yeah.
That is Vermont.
Yeah, most of my whole life outside of the urban area, so like how we're reaching people.
I was looking at number 3.
Yeah.
And I think equity-based is such a broad term. And when we're talking about integration of mental health in primary care, what really needs to be explicitly said is, I don't know whether it's training or addressing or whatever, implicit bias that primary care physicians, nurses, and so forth have and don't. I mean, by its very definition, implicit means you're not doing it on purpose. You don't even know you're doing it. But there's massive amounts of implicit bias. And I recall when community mental health centers started offering primary care as part of the services at their sites. And of course, that's duplicating resources in terms of workforce and all. But the rationale was they can't go to primary care because they're not accepted, they're not welcome, you know.
Yeah.
There's a bizarre thing, maybe not so, that has stuck in my mind for, okay, so how old am I now? So for 50 years, because when I was in my late teens, I was training to be an EMT and was therefore doing emergency room monitoring, whatever, helping out. And I knew nothing about and had no interest in mental health issues. A woman was brought in who had attempted suicide. And I was watching, they were all around her and all that. And she smelled.
Yeah.
And one of the nurses said, no matter how she was feeling, you would think she could bathe.
Oh,
And that just stayed with me.
Yeah.
Like, boy, excuse me, she attempted suicide. Do you think bathing is on top of your
Right.
mind?
Irrelevant right now.
Or relevant, right? I mean, talk about that, you know. Oh, and you've never addressed somebody with a broken leg, you know,
yeah.
who smells for some reason. I'm sorry that I just never forgot that.
One of the things that Leslie had said is by having embedded peer specialists, you're also working on the stigma with those medical providers.
Yes.
And so it's great to
Yeah.
open up non-traditional
Mhm.
medical practices or facilities or availability, but also having that embedded peer specialist and breaking down those implicit biases. And
Of
so,
course, well, not with the peer specialists, but some of the, you know, there's the other side of it is a lot of, well, that's more workforce, that's not primary care, but even, you know, mental health providers who are sometimes embedded in primary care, carry their own implicit bias, so
Right.
that doesn't necessarily help.
right,
So,
I think there's also a conversation in here about intersectionality, right? Like, so it's not not yes, and with
Mhm.
that the bias that might be set up in the system between healthcare providers and mental health providers or mental health people
yeah,
experiencing mental health crises. But then there's the question of like what that looks like for different groups, right? Whether it be a different cultural group or a different racial group or a different LGBTQ plus. So
Yeah.
it's that piece about.
Yeah.
makes it
layers.
complicated,
Right,
yeah.
so that's where for me that like equity based is more about like it's less about being based and more about the way in which equity is woven into because like that the disparities are complicated, right? They're not just
right, linear. Yeah, one of the things, you hear bi-directional, we've had bi-directional kind of in our system, at different points. And, but then someone had brought up, what was the term, multi directional.
Mhm.
So it's not, it's no longer bi-directional, it's coming from all over the place and it's coming, so that could be true,
No wrong door
Right,
kind of approach.
right.
Yeah.
I just don't know enough. I mean, I'm not a subject matter expert, like adjacent to much of the work.
Yeah, no.
But it's like, as I listen to folks, listening and talking, I'm thinking like, what does that look like? For recovery.
Yeah.
Support, yeah, how does that look in, say, a refugee community?
Right.
Chittenden County as opposed to, you know, maybe a rural community in Orange County, like, it's like, those are different,
Yeah,
different.
it's challenging, yeah. I know we've thought a lot about it in Rutland, because we tend to get all these different forces who have us looking at issues around, like race and culture and so on. And then, we also have this knowledge that like so many of the individuals that are in our community who are likely to be in the emergency room for, suicidal ideation, or who are overdosing, they're single, middle-aged white males. And so like, we're trying to feel like, how do we make sure that we're providing access to all these different like sort of, subpopulations within our community, and also like still finding ways to make sure that the majority, so to speak, are accessing care too. Like it's so broad and complex.
It's funny you said, because my mind is just going to, people are not accessing care, because they're
Yes.
white males, toxic masculinity.
Yeah. Yeah.
Toxic masculinity,
Yeah.
there's different needs.
Yeah. Absolutely.
Is there anything about the other two, number 2 or number 3? I know we touched on number 3 a little bit. Sandy, I also don't want to neglect you, so please chime in. Okay.
I'm wondering if number 2, sounds like, that's like, non-integration in the sense of, because a lot of the discussion is expanding the use of recovery coaches, peer support specialists, and community, people who are chronic peer supports. It's all of them. That this kind of seems like a narrow focus to just dealing with strengthening ties within the substance use system, which really doesn't integrate it either. So primary care topic, it seems like that should be broadened some.
Okay.
In terms of expanded use of, peer support, as recovery coaches and as, for all of the different disciplines to strengthen ties within the primary care system, because that's this topic.
Would it be like an including but not limited to? I mean, I don't know the world beyond this too.
But this is talking about strengthening recovery coaches, strengthening ties. I'm not sure I understand that, because if it means recovery coaches, in order to have primary care strengthen its ties with the substance use system, I guess that's what it means, and I was misreading it. It's like strengthening ties of recovery coaches within the substance use system isn't addressing the topic of integrated, but I was reading it wrong.
But it is an interesting point, right? Like, like the strengthening, it reinforces, cooperation rather than
Right.
integration.
Mhm.
And I think I heard you say that.
Mhm.
So if you're reading it wrong, this says to me, we need to.
But I would expand it to say what the Fuller pieces did as number 2, that it's about expanded use of recovery coaches and, et cetera, to
Yeah.
strengthen the ties, as a first step towards full integration. It's like,
Yeah.
that's not full integration to just have strengthened ties, but it's an important
Yeah. That
initial.
makes sense.
Yeah.
Because it's not, it's like
Right.
Toward.
Right.
Right. And because in all of healthcare, you have specialty care.
Yeah,
Not everything happens in primary care.
yeah,
You're still gonna have a substance use system as the specialty. You're still gonna have private psychiatrists as a specialty.
yeah.
But that primary care integration also has to happen.
Yeah. Oh, go ahead, Sandy.
And sometimes, and I don't know if it's my sensitivity button, but I feel so much of everything that we put in, we're talking about it through an adult lens primarily.
That's
And
why
when
you're
we're
here.
talking about, and when we're talking about primary care, especially, through any language that says across all age populations or whatever, I don't think I've seen too often.
It's a great point.
Yes. Particularly both for 1 and 2 here. Because when you're dealing with primary care with kids with a lot of needs, peer support for parents in that primary care setting is like so important.
Yeah,
Right, right. That's.
And now when we're looking at substance use against cross adolescents,
Yes.
that's a whole nother level where, because of our ages of consent, parents might not be involved. So
yep.
Yeah, and that goes to the issue of, and I think it goes to integration as well. That age of consent issue that there needs to be good training and understanding that the age of consent doesn't mean you can't be and shouldn't be making every effort to work with the families and encouraging. If you're working with a young person who doesn't want to share with their family, who might have good reasons, but that part of the work is to build those bonds so parents can be involved because the kid feels more comfortable with involving the parent.
And also parents might have to bring that. I was thinking a lot earlier, it's funny, let's come back to this at this point in time. I was thinking earlier in today's conversation, during the first part of the day, when we're talking about whole family, I was thinking about like whole individuals, and whole families, and then whole systems.
Right.
And the way that they're multidimensional,
Yeah.
each of those levels.
I'm thinking as a good example, when the legislature lowered the age of consent for getting mental health counseling, and people were objecting to, parents' rights and so forth. And I said, okay, so your mom has gotten a cancer diagnosis and is severely depressed. You are now feeling overwhelmed and depressed, and you're going to your school counselor and you're begging the counselor, don't talk to my mom about it right now. She will get more distressed if she knows the impact it's having on me. Please. Well, we want that kid to be able to not involve the parent at that stage, because otherwise the kid's going to say, well, I'm not even going to talk to you then.
Right.
Because he doesn't want to put more, and that's because the mother has needs too.
Yeah.
And that has to all.
Yeah.
And it's so profound too, and with adolescents with substance use issues, because it's also what they're doing is illegal. And so the fear around talking about it is huge.
Yeah.
Because it's not just the stigma, but also the fact that it's illegal behavior.
Right.
And so
What if my
there's so much
parents
fear.
turn me
Yeah,
in?
yeah,
Right.
or anybody finds out about this,
Yeah.
what happened to me and so on.
Yes. And I think about when you brought up the toxic masculinity we have in Vermont. Is there also, does that trickle down to potentially parents not wanting their kid to receive mental health supports because it's weak or it's, those are family issues. We keep them here. We keep them in this house. We don't share them with other people, is that also?
Yes, I mean, I had a goddaughter who was at boarding school, and they required the consent of both parents to have her get counseling. And her father, who was the problem, would not consent.
So then they would not provide any.
So she could not get counseling around the incredibly challenging relationship with her father. So,
Ugh. Makes my skin crawl. But
well, he ended up, I think, probably realizing the error of those ways, and she now has a different last name because she wants no association with him. So that's where it
Yeah.
ends up. Anyway,
it's true. All right, any other thoughts about any one of those three that we have?
no, and I did skim the other two, which I thought were both wonderful and right on target with
Good.
what we've been discussing, right? The retain is
Yeah.
kind of applies to workforce and
Yes,
this, just
it
like
does.
all of our groups
Yeah.
have cross.
Yeah, and we often said that at the beginning of this
Mhm.
2-year track of like,
Mhm.
sometimes we wish that we could just join forces, like the pediatric with the primary care or workforce with primary care, like.
But then you
there's
can't
so-
have the
I
small
know,
group discussions, so
Yeah,
you're stuck with
I
it and
know.
the department has to pull
Yeah.
it all together,
Yeah.
yeah.
Kathy does.
Kathy, Kathy gets to pull it all
does.
together, right?
All right, quick, just move.
All right,
Stop talking.
so we're moving again.
I'll tell you, I
Sandy.
have gotten phenomenal feedback from hearing from hospitals and so forth about the trauma-informed training that BPQHC
Yeah.
is doing with the emergency department,
Oh,
which includes a peer support person
yeah,
with 2 others doing this training.
oh, that
And the
is,
staff are saying they never had something so good and so useful.
oh my God, that's amazing. Oh,
And all the.
all right, Sandy, do you know where you're going next?
I don't know where I'm going.
So, if have you hit 3 out of 4 of the work
I-
groups?
I have hit 3 out of 4.
Okay, so go to the one that you have not been to yet.
Well, that makes perfect sense. Thank you very much.
Okay, thank you. Hi,
How's it going?
good. Is it just you and I?
I think it's
Is
just
that your
us.
whole group?
This is my group. Well, Sandy was in peds with me initially, and then I think I just went my own way.
Oh,
So
you branched off.
I.
Um, so we have, these
Oh,
two,
so this is the only thing.
this is, yep,
Or-
you can take that. That's recommendations for
You
the,
join your group.
Oh, great.
Say I came to one other session. Besides the Here, do you need?
that is, I would share mine, but this is the
I
mess
should
right
know
now.
what's going on in this.
You should.
Things keep happening. you
Oh,
know?
I know. So that's the recommendations, the interim recommendations.
Okay.
These two are the feedback that we have received this far. This is from Retain. This is from Will Ebery, yeah, thanks. Recovery Vermont. And so those are 2 pieces of feedback we received so far. So please feel free to take those.
Train people are very interested in
Yeah.
working with us.
Yeah,
I have to admit, I was like, it's great.
I know.
And
I know.
yeah.
They're actually going to present at our DMH conference. So if you guys are going.
they're grant funded until they're not.
Yeah, yeah.
And it's very interesting work. Which I think is applicable. But it's a niche part of this. It's
It
not
is.
the whole thing.
Yeah. Agreed.
Although in the Peds group, I was saying like, man, if I had known what their mission was, it would have been great to include that in pediatric care, because like that's the parents.
Yeah.
Yeah. Like how do we, yeah.
And they must have joined this late, right? Because they weren't,
Yeah,
I
they
think,
showed up at a meeting over the summer.
yeah. Yeah, so I think that they were late to the party, but have been super helpful. And I had brought this up in the last group, how useful that was to hear about the mental health kind of crisis that medical providers are experiencing now, and how many are, like, no one talks about that.
Perspective.
Yeah.
There's a New York Times piece 3 weeks ago about the moral crisis in healthcare.
Ah,
It was like a nice
yeah,
reminder that, I mean, a bunch of my colleagues are out right now,
yeah,
or cutting back their time, or retiring early, yeah. It's not great.
yeah, no,
Not a good
which,
look. Nobody ever used to retire now. It's like
yeah,
epidemic. Yeah.
yeah, it is. We're seeing it in, the medical field, seeing it in the mental health field, seeing it with teachers. Like, there's just this helping profession is exhausting people. Um, so one of the,
So the retained feedback probably belongs there as much as,
yeah,
yeah,
agreed.
I mean, obviously primary care, we're concerned about workforce.
Yeah,
But at the same time, we sort of have another group.
yeah,
Done
it
that.
could cut across many.
Yeah.
And they were great. They came and shared perspectives in the first group before they moved on, but they were super helpful in talking about not providing care. Well, let me start over. So some of the feedback that we've received on this first one so far that kind of kicks us off is Vermonters seeking care should have whole health support. And so the piece of feedback is you're eliminating or discriminating against a whole subset of people by saying seeking care, because there are many people that will not seek care. People with severe mental illness, they don't go and seek care. We know that they actually are experiencing a lot of medical issues that they don't seek care for. And then the second part of that sentence is the whole health support. And so wanted to know a definition. Everybody's coming at, what does that mean? Coming at it from a different perspective. In each one of the groups, they thought it was something else. So do we have a definition somewhere of what that means? And so another piece that we talked about was providing care or building rapport in non-traditional medical settings. And so George from HCRS said they're outreaching to the library to have someone embedded there that could help build that rapport of people that go to the library. We know often homeless go to the library, spend their days there. Could they build that relationship and then help them to go to primary care? Or is there a peer specialist that could be at the library that builds that rapport that helps bridge that to primary care? So those were some thoughts around like looking at the first recommendation. The other,
So.
go ahead.
Just,
Yeah,
while my thought is fresh, we can reframe the sentence as the integrated system of care should have a whole health focus.
So even just Vermonters
Right.
should have whole health support.
Yeah, or, right, Vermonters in general, that doesn't limit it to those who put themselves into the healthcare system.
Right. Doesn't matter if you have insurance.
Yeah.
English, everybody has.
Yeah, whatever way we say it, it just becomes inclusive.
yep,
It does raise an interesting question. I appreciate just starting this. Like, if this is the primary care group, this would assume people are enrolled with some sort of primary.
right, right.
Like, it'd be cool to just walk down the street, or like when we're doing those, the night in Burlington where people go out and sort of do
Oh, yeah.
outreach.
Yeah,
Like,
see,
we should doctor
yeah,
and just see how many people have a response.
yeah, yeah,
Versus, because ultimately it seems
yeah,
the assumption is people are engaged with some care.
yeah,
So they've got somebody.
yeah,
And in Vermont, we probably have the highest rate of people who have primary care clinician in their life. But let's say that's 85%. That still leaves a lot of people.
15%.
who can't answer that.
Yeah,
question.
yeah.
it makes me think of, my son is 20 and his pediatrician sent him a letter and saying, hey, you're now an adult, you gotta move on. So I said, Lane, we need to find you a primary care physician. He's like, why? I don't need one. I don't need,
I don't need insurance.
yeah.
I need a doctor.
like, well, yeah, my insurance. Exactly. I don't need to go see a doctor,
Yeah,
and
yeah.
so we still don't have one for him. But
And it's getting
It-
harder to find.
oh yeah,
It's impossible.
Yeah.
We just hired a new child psychiatrist for our clinic. And he was like, I can't get it up. So they live in South Burlington. They're going to like the Georgia Medical Center, Georgia Clinic.
God,
It's like, dude, you're a part of the
yeah,
veil of an academic institute.
yeah.
We should do better. So
Oh wow.
pull some strings.
That's what you do.
That is what you do.
That's what you do. So,
Leverage your position.
oh, damn.
It is sad. That's how it has to be.
Yeah.
So then the other feedback to get us talking about number 2 around explore expanded use of recovery coaches and strengthen ties with the substance use system. So that's kind of a vague statement. And so the thought was, where's the integration? And so we need to really tie it back into the integration with primary care. So should it be peer specialist and recovery coaches strengthening ties to primary care? So felt like we needed to reword the second.
Is the other intention just like expanding like hub and spoke type stuff?
Yeah, I think feeling that, if I remember this right, this was the feeling that there's just not enough. They really wanted to focus on recovery coaches and substance use within primary care, and feeling like that we've done a great job of having them in emergency rooms, but we don't see a lot of recovery coaches in primary care. So we also, in addition to peer specialists, we need recovery coaches to be within primary care practices as well.
Are recovery coaches parts of MAT teams?
Are they what?
Are they a part of MAT teams?
Great question.
Like, that would be an easy.
Yeah.
Let's just take MAT teams and add a.
For an individual, they're part of their recovery process. So they usually get hooked up with them through the recovery center.
Yeah.
As opposed to the treatment center.
Right, okay.
But you're right. I mean, it should be kind of a thread that goes through everything.
Yeah.
And if we have like infrastructure of MAT teams in the hub and spoke model, it would seem that's the easier and add to a team that doesn't mean having a separate complementary
Yeah.
parallel system.
Certainly at the hub level, other than the recovery center.
Yeah, yeah.
At the spoke level, I have trouble envisioning.
There may be some organization where.
I don't see it.
Yeah.
It may exist in some spokes, but
I don't know.
I don't feel that.
but you're right. By definition, if you're in a spoke or on maintenance buprenorphine,
Yeah.
you're in recovery.
Mm-hmm.
And you have the clinician who's writing the prescriptions and meeting periodically. You have the one either nurse level or social work level kind of support person who's part of the deal in terms of the design of the spoke, who I hope could make that connection, but I don't actually know.
I don't know if they would have the time, because my sense of like how
Because
this
it's
is,
another thing.
they're quick.
Yeah.
Like quick visits.
Yeah.
20
Yeah.
people in it. Wow.
So,
Wow.
yeah, but making it a sort of 3-legged stool.
Yeah.
Social work around sort of SDOH stuff.
Yeah.
Person to write a prescription and, hey, you've been coming here for 6 months and you've been paid for 6 months. Our story. What could you share? How do you keep this going?
And is that a way of supporting the workforce of getting people? You're in recovery now. We do have openings in recovery coaching or
Yeah.
in peer specialists. And so Leslie was saying in the group before that outside of Vermont, peer specialist is highly competitive. And it's really hard to get a job as a peer specialist in other states. And that's just not not the way it is anymore.
No.
And basically you're begging people to enter the workforce. And so, so yeah, we're kind of way behind the times in Vermont with the peer specialist work.
Across the parking. In the other building. You know, I'm sorry to go back to the first one. But when I think about whole health support, I think about primary care, I think about my colleagues who have enough paperwork for their well visits, for instance, or like an annual exam.
Yeah.
I worry about what, like, what the burden will be on primary care. Or pediatricians and physicians and family docs and whatever. Like, what I don't want is whole health support to need another checklist.
Yeah.
For sure.
And like, I appreciate the embedded staff person, but you know, I worry that that person's gonna get booked up.
Yeah.
You know, I'm gonna talk to you about your needs and I'm gonna keep talking to you like I'm supposed to be also talking to you. I don't know, I fear that sort of as with teachers, we're just gonna end up putting numbers.
Yeah.
Well, that's
Yeah.
the last thing they need.
Right.
That takes.
In the work of bringing in a peer specialist or recovery coach with primary care is to help alleviate some of that pressure that they're feeling, but by doing that warm handoff to someone else.
Team.
Yeah,
Yeah.
but I don't know. I don't feel confident in that yet.
Yeah, like even some of these things, like in bearing all parents' trauma or is
Mm.
right on spirit and
Mhm.
aspiration of it. Like, you're 3 deep.
Yeah.
And it's 4:30 and you're
Yeah.
go to your kid's soccer game. That's gonna be the first thing to go.
Yeah.
So I'm nervous about.
Thing about the primary care spokes, it's also the majority of substance use prescriptions written by
Us.
so an individual practice may actually, let's say they have 10 people,
Yeah.
it's probably locked. Most people who using the X waiver when you had to have it, really had the smaller end of the scale. People that suffer. And then there are people who are more primary care oriented addiction specialists who are writing tons of those prescriptions. Much of the practice is population.
Yeah.
So you have to be careful because if you embed somebody within practice, they need enough critical mass to make it possible.
Yeah.
Which is challenging, but I mean, the theme is still tapped good.
You know, one thing that I was just thinking about as we think about adding more people and more warm handoffs to mental health and to substance and to social work.
Yeah.
Is exhausting and I don't know. I worry that something that could come in here is like, yeah, thinking about workforce retention for primary care as like a very specific call. We need more people to go in and stay in primary care and not just want to be a fancy specialist and get out of primary care.
Do they get out of primary care because of the demand of the administrative demands?
I think that's a piece of it.
That is a
And like
piece of it.
managing the mental health burden when
Yeah.
there's nobody else to refer to.
Yeah.
The workforce piece. Especially, I was looking at the AHEAD stuff on the CMS's
yeah.
website. If we're gonna enhance primary care, piece of it's just making sure we have the primary care clinicians that
Yeah.
work, because they're all beating it for, you know, derm or something in med school
Yeah.
onwards, then we're screwed.
See, we're also, I'm not sure where this thread went, because a lot of this is in support of the primary care clinician with building a system of whole health support.
Mhm.
But the one place that I'm not seeing the support of the primary care clinician is in the actual ability to have the work of the mental health piece accomplished. You know, we have the UVMMC model of embedding somebody in practice or having them available by phone and electronic communication
Yeah.
through look at charts and make comments, etc., or to actually see people. Then we have other ways of addressing that just give the primary care clinician more resources in the challenging aspects of mental health. Counting.
Yeah.
Because it's easy to sort of like have these people in your practice who can make a whole health kind of focus, but when push comes to shove, there are still going to be people who are challenging to manage
Yes.
with their mental health disorder.
Yeah.
And in that moment, you don't want a phone call. You want something to
Yes.
say, I got this.
Yeah, right. Right.
And is that gonna be primary care physicians embedded with mental health agencies? So they're still.
Oh, like a reverse.
Mhm.
That has to have, like, it's a
Yeah.
CCBAP,
Yeah.
Right.
that's
Yeah.
supposed to happen to some degree, though.
Yeah.
I don't overdo that.
Right.
But I'm really concerned.
Yeah, yeah.
The other way,
Having- yeah.
like. the
Because the
primary-
primary care clinician is as frustrated as the patient when they say, I'm gonna send you to somebody. They'll never get them in to somebody.
Yeah,
They can get a psychologist appointment. And that may be the level of care that is critical.
Yeah.
Primary care clinician can't spend all that time in function. But if they need actual medication management, psychiatric expertise,
Hmm.
they're gonna be like.
Yeah.
And that's where it's so
Just-
frustrating.
yeah. Yep. And that's a workforce issue,
Right.
having enough psychiatrists.
You can help me
Yeah.
if the workforce issue in psychology
Sure.
is grave. My sense is more of access, but I don't want to.
They're spot on. And I think, I mean, it's interesting. So in deep primary care, like a bunch of the pediatricians are getting extra specialty training to basically
Yeah.
light versions of child psychiatrists.
Oh,
And
Because there's nobody.
because there's nobody else. And even with these consult models, it's really cool, but it actually makes more work
yeah,
to send you the
Yeah.
message,
Okay.
your doctor
Yeah.
suite, what do I do? And to get the response back, try this, this, and this, and then you
Yeah.
have to like, it eases some burdens, but it also adds some burdens. And what people want is colleagues, not consultants.
Yes, exactly.
And,
Like when I had my practice in internal medicine. With 3M, it was during that period of time when we had half a day a week, of somebody in our office.
Yep.
And we could refer our challenging cases to that person. And we could get sidewalk consults with the
Yep.
person.
Yep.
And we can also, have charts, just sort of say, take a look at this
Yeah.
and tell me if I'm on the track or why, what else can I do? Because what are my ideas?
they go half a day a week of a psychiatrist.
Yes. It was wonderful.
Wow, yeah,
Wonderful. And now that's part of the model that Maureen presented to this
Yeah.
group was, how they've tried to keep that part alive in some way.
yeah,
Right.
And pay for it and everything else.
Right. Right.
But we're trying to be more generalized here across
yeah,
Yeah.
anybody.
yeah. Any kind of mental health.
Yeah.
Yeah.
Because we all have our go-to people in the psychology world that we can refer to and try to connect with. And know that patient's in a good place.
Yeah,
And generally, there's not a lot of communication that comes from the itself when it has to.
right,
But then there are cases that need a little more.
yeah.
Yeah. And there's
That
another
needs more
way
than
that
just peer specialists, more than that.
if we accept the fact that 30+% primary care is actually mental health.
Yeah.
Yep. Percentage of that is going to be challenging.
Yes, yes. Well, even I'm thinking about like, just, and this may be something to do with like the Vermont Medical Association, or whatever, but like, just doing the extra round of needs assessment, what do you guys need?
Yeah,
Because like,
Yeah.
there's some assumptions built in here about more staff or substance, which is cool.
yeah,
But I think, I don't know that as I read through it, I'm sorry, just like scanning.
No,
it,
that's-
like, I don't know that my colleagues' voices are represented.
no, no, we couldn't get a primary care on our group. So, which is very telling,
But
right?
that's
But
like some of those, yeah. Because they're all writing
Yeah.
prescriptions for children. Trying to wonder who's gonna get sent to the Jared House next. So,
Oh,
yeah. But the work, something about workforce would be really cool. I don't,
Okay.
I'm sorry to like,
No, you-
however, be like,
Yeah,
so,
it's your world.
yeah.
It's true.
Yeah.
Yeah.
I want to, I want to do my colleagues for a longer time. than
yeah.
2 years. And they're done. So,
Okay, I think we're coming to an end. So anything else about anything you're seeing?
I'm just sort of on the kid side, like.
Yeah.
The other thing that trips us up all the time is like, what do we do about autism?
Yeah, yeah.
The way it's far beyond the scope of like this type of report, but
Oh.
there are these like little pockets of high acuity coordinated
Yeah.
care, which the system just not set up for.
Yeah,
It falls back to PCPs
it does.
and like
It
triage
does.
nurses who get very.
Yeah, yeah. Yeah,
What's
and maybe,
the acronym of the program?
Oh, the CPAC,
CPAC.
Cloud Skype Access Program.
Yeah.
Somehow trying to answer the question I posed just here
Oh,
in pediatrics.
so that's like Greta sponsors them from the community health centers.
I don't know.
I think so. Yeah, so Greta